Very good afternoon, ladies and gentlemen, young men, young ladies, future doctors of tomorrow. My name is Barbara, and you're tuning in to the Malacca Manipal Medical College webinar series, The Doctor's Road to Specialization. Today, we will be featuring the specialization areas of pediatrics as well as obstetrics and gynecology. On our panel today is Professor Dr. Sunil Kumar Jatana, as well as Professor Dr. Somsubhra. They will be sharing with us their experiences in terms of how they decide to go into the fields that they have decided to, what is it like, the ups and downs. We'll also tell you a little bit about our MBBS programs, and we'll take question and answers towards the end. Should you have any questions that you wish to ask our panelists, please use the chat feature available on your screen. So without further ado, let me introduce our panel speakers for today. Professor Dr. Sunil Kumar Jatana and Professor Dr. Somsubhra. Good afternoon, sirs.
Good afternoon.
Good afternoon.
Thank you so much for joining us. And I'd like to tell our audience a little bit more about you, okay? So we'll start with Professor Sunil Kumar, who did his MBBS as well as his MD in pediatrics from the Armed Forces Medical College in India. With over 36 years of service in various teachings and other hospitals within the Armed Forces of India, and right up to the year 2014, where he then moved into academia. Since going into academia, he's been active in publishing papers with regards to the field of pediatrics. Good afternoon, sir.
Good afternoon.
And joining Professor Dr. Sunil is our very own beloved Professor Dr. Somsubhra. Afternoon, Professor Som.
Afternoon, Barbara.
I hear you're tuning in from the Pearl of the Orient, Penang.
That's correct.
Excellent, excellent. I hope you've got a good view there.
Lovely view. I've done a lot actually for past 2-3 days. I'll tell you when I get back.
Yeah, excellent. Now, Dr. Som is a Manipal boy through and through, having done his MBBS as well as his Masters of Surgery in OBGYN from Kastuba Medical College. He's also of the Fellow of Academy of General Education under Manipal Academy of Higher Education, MAHE. He's a Philippi Fellow, and that comes under the MAHE Farmer International Institute for Leadership in Interprofessional Education. He's also completed a faculty of certificate in online teaching from Global Next University, which is our online university within Manipal Group. Apart from being a professor in OBGYN at MMC, he is also NSR accredited, which is the National Specialist Registrar Malaysia, and he offers his clinical services in Jasin and Malacca. Above and all this, he's also the advisor to our student council for the last decade and an ardent Toastmaster for the last 5 years. So thank you so much for spending your Saturday afternoon with us, sirs. We hope that our viewers today would be able to learn more about the field of pediatrics as well as obstetrics and gynecology through your sharing.
Yes.
Perhaps we'll start with a brief on your area of specialization. And if we could have Dr. Sunil share with us, what exactly is pediatrics?
Well, pediatrics, normally we deal with the treatment of children right from their birth till the age of 18 years. That includes the adolescents also. Okay. And we do care for children on daily basis, treating them or whether we are following their growth and development, because you see children, we have to follow their growth very, very closely. Any faltering in the growth means the child is not attaining proper health. So besides treating whatever the ailment the children have, growth and development is a major part in the children's looking after. So we normally, we help the children to live the normal life as normal as possible throughout the ailments also. It's a very demanding and challenging specialty. But then you get a lot of rewards in your career. Maybe the biggest reward, what I feel, is when I see a patient improving and a child improves, give you a big smile. That is, I think, the biggest reward a doctor can get from a child. And of course, besides that, you can do a lot of research work if you want to. And what you can practice is a lot of teamwork. Teamwork is required in pediatrics. By in pediatrics, I think in any specialty, you require a lot of teamwork. You require trust among your own colleagues. You have to trust the paramedicals because you cannot be with the patient throughout the day. So there's somebody else who's looking after the patient, maybe the MO, maybe the sisters there. So the trust has to be developed among the team. That's a very important issue.
Mm-hmm, mm-hmm. And in terms of pediatrics, sir, I mean, how widely known is it? Because you're responsible for the healthcare of children right up to the age of 18. But
Yes.
a lot of the times, parents would bring their children to a pediatrician, when just shortly after they're born, and then they move on to a GP. So it's a very fine line there between taking a child or a teenager up to the age of 18 to a pediatrician or a GP, isn't it?
Yeah, it is. You see, it's not that every day there's a challenge for us. In fact, because we have to see in the morning. Maybe we're going to the neonatal nursery, seeing a newborn baby there. After that, maybe in the OPD, we are seeing a child who's about 6 to 7 years of age. You've got a different kind of an ailment. Newborn baby will have different problems. A child who's about 5 to 6 years, maybe having a respiratory problem, come with cough, maybe having a pneumonia. While a teenager maybe having a different problem, he's gone to play outside, got injured himself. And the first contact for a child will be a pediatrician, whether it is the child has got injured in a play field, or whether the child got earache, or whether the child got some problem in the eye. You'll always find a child is always brought to a pediatrician first. Maybe then we first have a look, and then we refer, maybe if required, to other specialities. So we have to have a wide range of knowledge, right, from the common problems what a newborn faces and a common problem what a teenager faces. So it's a very demanding subject, and we have to change our roles in a day itself. So but on the other hand, I'll say it's a very rewarding specialty also, because when the patient improves and when you can convince the parents also. Firstly, another very important challenge is to take the parents into confidence. You have to discuss the problem the child is having because they're very worried. And if an emergency comes, the parents are really terrified. They don't know what is going to happen to the child. So they want the child should be absolutely fine, well, playing around, running around, and give them a lot of cheer. So we have to take the parents, we have to counsel them properly, tell them what exactly the child is suffering from, what problem is he or she having, is the treatment available for that, how long will the child take to improve. So there are some questions which sometimes we may be able to answer, sometimes we may not be able to answer also, but definitely we have to try and console the parents also at times the child is not doing too well. So it takes a lot of patience. It takes a lot of hard work also.
Yeah,
So
I would think it's one of those field where one patient effectively you have three, because a child will always come with mom and dad, and you've got to manage all three.
Absolutely.
And similarly with Prof. Som,
Yes.
Prof. Som, Obstetrics and Gynecology.
Yeah. Well, if you ask me in a very simple way, like what is the area of specialization, I would say whatever the lady suffers is in obs and gynae, but that's putting it very, very broadly. So that's why I've divided into two aspects, since it says obstetrics and gynecology. Obstetrics, to put it a bit simply, it deals with any ladies who come with normal pregnancy, could be complicated pregnancy also, but pregnancy and childbirth and delivery of the babies. So this particular area comes under obstetrics. Whereas the gynecology mainly deals with menstrual problems, issues, or any problem of the female reproductive organ. It could be a non-malignant, or it could be like cancer related as well. So cancer of the uterus, ovaries, or cervix, all these kind of problem. From the tiny bit of problem to the major bit of problem. Now, when it comes to
gynecology include fertility?
Yes. That also part of that's actually a subspecialty called reproductive medicine.
Okay. All right. Now, these are very, very interesting areas, and I'm actually fascinated that I'm speaking to two male specialists in this field. So I'm curious to know, how did you decide on your specialty, Dr. Sunil?
Well, let me tell you very frankly, I was initially, when I was in the school and all, I was not very keen to become a doctor. In fact, my father pushed me into it. He says, no, there's no doctor in the family. You see, both my elder brothers, they were engineers. So I said, no, we should have one child who has to become a doctor. So I think you must take on the responsibility and become the doctor in the family. Let me tell you, that was the first thing which attracted me to becoming a doctor. Otherwise, I had set my mind to follow my brother's footsteps and becoming an engineer. When we were young, those days, especially in India, there were two major things to do. Major, I should say, the professions which you used to choose from. One was an engineer, other was a doctor. So if you can't become an engineer, you become a doctor. So that was my family's pressure that I became a doctor.
Okay. And were you the eldest in the family? Because
No,
I think that
I was the youngest. I was the
you were the
youngest in the
youngest.
family. Yeah, I was the
Okay.
youngest in the family. So,
And
like I said, both my older brothers were engineers.
right.
And there was a gap of almost about 10, 11 years between my brothers and I. So, sort of family pressure, I went into medicine. Of course, then no regrets after joining medicine. But it was the family pressure which pushed me into doing MBBS.
Okay. But choosing pediatrics, I would think that, that it would be something that, that there's a love for children, for caring
Yeah,
for children. Yeah.
absolutely. My love for children attracted me to the specialty. And of course, like you see, like I told you, I joined the army after doing my MBBS. I was in the army, and I used to see families staying there because in army you have a lot of what we call as the field areas. That is where only the person is allowed. The families are not allowed to go. The families have to stay back in the peace areas, and they have young children. So I used to see the young children sometimes, having ailments, and the families had to rush to the hospital. So I thought, why not become a pediatrician, and then give some succor to these children who are suffering so much. So that
Yeah.
was a second aspect which pulled me into pediatrics.
Okay.
And let me tell you also one thing, because when I took up pediatric, because there's some sort of a gap in army, after you finish your MBBS and you are chosen for the specialty, we have to sit in a competition, of course. It takes about 6 to 7 years to go into the specialty after that. So then in the meantime, I got married. I had children also. When my son was small, I used to see him suffer at times, having respiratory ailments, having normal, like pain, abdomen and all. And every time we had to rush to a pediatrician. So I thought, why not? Why shouldn't I become a pediatrician? And that, of course, is another point which made me choose the specialty.
Wow. I'm going to ask you later, was it challenging? I mean, managing your wife as your
Yes,
patient's
yes.
mother.
Yeah, it is definitely very challenging. And because being in the army, we had to move from one place to the other. And every 3 years, we used to be moving from one city to the other city, from one hospital to the other hospital, sometimes being in a small hospital, sometimes in a bigger hospital, where I used to be the only pediatrician having a large clientele there. So I had to devote a lot of time to the hospital. But then I had responsibilities toward my family, towards my wife and children. But
Yeah.
thanks to their support, I could wait through those difficult times. And yes, and a lot of support from the parents of the children also. They knew that sometimes, when I do get emergencies, one emergency is coming, I'm handling that, and suddenly you get another child also who's pretty
Yeah.
sick and comes to the hospital. So
Yeah.
that becomes a challenge when you're the only pediatrician there. So, but then I think due to my hard work and sincerity, parents also used to understand. Yes, the doctor is also under a lot of pressure, so we must support him by not troubling him too much, and every time poking their
Yeah.
nose there and what am I doing and how am I treating the child. So got support from all over, from the administration, from everyone. So
Okay. Okay. Prof. Som. Prof. Som? We seem to have
Yes,
lost
yes.
Prof. Som.
Can you hear me?
Yep. We can now. We can now.
Yeah. So in my case, what happened was my mother was a gynecologist.
Ah, okay.
So but my father is a non-medico. So every time like dinner table, I would be hearing a lot of terms like cesarean sections, this and that, all gynecological terms. So I basically grew up hearing a lot of obs and gynae terms during our dinner table discussion. So I think it probably was ingrained into me that this specialty is something like, which I'm quite familiar with. Coming to the next portion would be my teachers during my MBBS days. Many of them were very, very inspiring, and when I went through obs-gyn postings and all, I felt like this subject is one I can deal with my instinct. Like when I feel something's wrong, it's wrong. When I feel this can be done, this can be done. So it built up my confidence a lot during that MBBS days. But having said that, I think Dr. Sunil also mentioned about the selections and all that. The rank in the entrance exams also matter. Just to give you a perspective, in India, because I did my master's in India, as you can see, um, up to 45,000 students write the entrance, and maybe like one third of them get into specialty. So it's a major pyramid system kind of thing.
Yep.
And you have to score a double digit rank to even think of obs-gyn. So anyway, that was always my first choice as well. And I felt like unlike other subjects, I'm very comfortable and I can think very clearly. It's very difficult to explain, but I mean, I felt like I can do this subject very well. So that's what I felt. But once again, I just wanted to point this out, that this is with regards to my pathway in India. In Malaysia, the road of specialization to OBG is very different. There's a MOH way and alternative pathway. I can take that offline with any questions later if they ask me.
Mm-hmm. Okay. All right.
Mhm.
I mean, it's always been a personal fascination of mine, that there is almost an equal number of both genders in the field of obstetrics and gynecology. When this is a field where you're really predominant, your patient is predominantly female.
Um,
So you must have a
well,
very
actually,
deep
that's
insight
not
into the
always
female
true,
psyche.
because certain part of India, there is hardly any male gynecologists. So I was very lucky that in the southern part of India, they are quite okay. But in certain portions of North India, they don't really encourage guys to become obs-gyn. Of course, the place I come from, that is West Bengal, there's almost 50-50, 50 male, 50 female gynecologists. So the ratio is very good. But there are challenges in India if you want to take up a field like gynae and a male gynecologist. Well, it's definitely also an added challenge. So I would say I'm quite lucky to be born in a state which was okay for gynae, and I studied in a state which was okay for gynae, as I mean a male to be a gynae specialist.
What about Malaysia? I mean, for both
Malaysia is quite
pediatrics
fine.
and
Malaysia is
gynecology.
quite fine.
Okay, so
Malaysia,
there.
actually, I would say there are more males, I guess, than
Mm,
female. But I cannot give you offhand statistics at the moment. But I think they're quite okay, because in the various hospital like Jasin and all, when I go there, they never said like, no, I want a female. Very rarely.
mm,
I probably got. Otherwise, it's always quite okay.
Well,
okay.
I'll just like to say one thing. So, like in your department also here in MMC, and most of the gynecologists are males. I think there are only
Yeah,
three ladies and the rest are all males.
yeah.
So yeah, so there are majority of males in the ONG department here also in MMC.
Yeah, but in
And
GH,
in
it's
terms of
actually a general hospital. It's quite an equal mix.
Mhm.
Prof. Sunil, in terms of pediatrics, do you find that there is some kind of bias to wanting to have a female pediatrician, for that motherly touch, that sort of thing, or it
No,
does not exist?
no. I've never found any bias as far as that is concerned, because parents take to the male pediatricians equally as to the female pediatricians also. Uh,
Okay.
but but biggest challenge you see in pediatrics is because the child cannot speak, the child cannot tell you what's happening to him or her.
Mm,
Is the parents who give you the history, because
mm,
especially a small child, if the child is not in, the child will just cry, and then you
yes.
have to imagine, or by your examination and your clinical acumen, you have to see what is wrong with the child. Of course, the mother is a big help there, because you have to treat the mother with respect, in the sense that whatever the mother says is the gospel truth. You have to believe that,
Yeah.
and you cannot take away from that mother, because she knows everything about the child. A
Yeah.
little bit here and there, child is not behaving today, that means it's something wrong. Mother will know more than the doctor, more than anybody else in the house. So if
Mm,
you taken a proper history from the mother, asked her what is the problem with the child, you can definitely come to reach a diagnosis and treat the child accordingly. So
mm.
that is one of the biggest challenges, because children cannot speak, they cannot tell you what's wrong with them.
Yeah, that's right. That's right. And your specialization, I mean, you basically train in the army. You
Yeah.
know, you
Yeah.
mentioned earlier a lot of moving. But what about the cases, the exposure, your mentors within the army?
Yeah.
A 36-year career in the army
Yeah.
spans a
Yeah.
long time, and we know
Yeah.
with childhood diseases, a lot of things come and go very rapidly. Could you
Yes. Yes.
share with us a little bit about that?
You see, Army has got a little different structure. Like we have peripheral hospitals, which are located in the smaller places. Then we have slightly bigger hospitals, like we call them the zonal hospitals. Then we have what we call the command hospitals. That is a bigger hospital, about 700, ranging from 700 beds to anywhere 1100 beds. And then we have one up, the most prestigious institute of our, you can say, the armed forces as well as of India is Armed Forces Medical College, which there we have a 1100 bedded hospital with the 200 beds which are only for civilian beds for teaching purposes. And
Okay.
we get a variety of cases there. We get a variety of cases, and because all this what we say what I mentioned is command hospital, there are referral hospitals from various places. So and sometimes we do treat the civilian patients also, but they have to pay for that. For army people, it's all free, but for civilians, they have to pay. So we do take in at civilians also, and treat the various ailments. So we do see a variety.
Okay, and you know I'm going to assume that when you first started your specialization, diseases like polio, measles,
Yeah.
they were big
Yes. Yes.
areas of
Yes.
concern, and
Absolutely.
over the years with advances of medicine and
Yeah.
vaccination, they
Yes.
went away.
Yeah.
Having said that, you know, I think it was about a year ago there was the comeback of measles, and how a lot of young specialists pediatricians failed to pick up on that, and that resulted in a measles outbreak.
Yeah, actually, this problem occurs more in Malaysia because here you hardly see any measles. Most of the parents, they bring their children for immunization. It occurs. I've seen even in India now the cases are there, but they're much less what it used to be earlier because parents have become more aware. They take the children for regular immunization, and this is one drawback which is there, that if the children, rather the students, don't see the patients, they don't remember. It's always that what the mind does not know, the eyes do not see.
Yeah,
So it applies here also. Yeah.
yeah.
But then yes, we do teach our students about measles also. We show them photographs and we tell them what the rash looks like, so they can identify these sort of patients. Fortunately for all of us, polio has been eradicated in most of the countries except for 3 countries in the world. So in India, there's no more polio. Malaysia, there's no more polio, and only a country like, I think there was one case in Nigeria, one in Pakistan, and one other country I'm forgetting. Three
Yeah,
countries are still left over. But
yeah.
that's advances which have been made by promoting immunization to a large extent. Measles also should have been eradicated by now because the vaccine is very, very effective and it does prevent the outbreak of measles. But unfortunately, sometimes, some parents think that if you give injections or you give vaccines to the children, they might become more ill. I don't
Yeah,
know. I mean, they learn from somewhere. I don't know.
I
And
know. And
sometimes maybe religion also, like some Catholics believe you should not give vaccine to the parents. Some other religions say no, vaccines are not. Let the nature take its own course. Well, the
yeah,
different type of things and thinkings
all
are
sorts
there.
of arguments from the
Yeah.
anti-vaxxers.
Yes. Yes.
Yeah, but over the course of your specialization journey, you have come up with some points that you would like to share with our listeners today, you know, in terms of what to consider if they're becoming a pediatrician. Would you like to talk us through?
What takes to become a pediatrician?
Yeah, like
Yeah.
some of the
Well.
things that they should consider, right?
Yeah. Well, of course, first and foremost, is if you have to become a pediatrician, you have to have love for children. That's very important. You have to know that are you committed to promoting the welfare of children? You have to be very sensitive. One thing, very, very sensitive. Be a patient listener. Listen to the parents, listen to the complaints what the child is having. Do not be in a hurry. Do not rush.
Mm,
Be empathetic. Not
mm,
sympathetic, but empathetic.
mm,
So, and take the parents into confidence. That's one
mm,
very important aspect. I think what we lack today, maybe because there are too many patients at time that we don't take the patients into confidence, especially the parents. We must tell them what their child is suffering from, what treatment does the child require, how am I going to treat the child, how is he going to respond to the treatment, what will be the after effects of the disease or the treatment what I'm giving to the child. So that's one very important, and for that communication skills are required. Unfortunately, we don't teach communication skills in the MBBS. And another thing is ethics. Very important to follow the ethics.
That's right.
Again, unfortunately, in some places, ethics takes a backseat, which is not a good thing. So we must practice ethically, practice modern medicine, but practice ethically. Money should not be the only consideration for us. I firmly believe in that.
Excellent.
Then you have to work as a team. If you're not a team man, then you'll be a failure as a doctor. You cannot do everything on your own. You have to depend. You have to have a good team working for you, with you, your MOs, your sisters, your paramedical staff, your staff in the radiology department, in the pathology department, because you're dependent on them to get your diagnosis. Also, you're dependent on them to give the proper treatment. You'll advise the treatment. Okay, you give this and this injection, but ultimately you give the injection. The sister will give the injection. So you have to explain to the sister. If you're always shouting at the sister, all your junior MOs and all, you'll find that ultimately who's the sufferer? The child is the sufferer, the patient is the sufferer. So a patient doctor, a patient doctor, I should say, and a team doctor. That's very important. Then you have to be slightly flexible also at times, in the sense what I'm trying to say that maybe you are struggling with a child, and you sometimes you feel your MO is telling you something. Okay, and doctor, what I think is if you give this medicine, this child might improve. Don't think that because he's junior to you, he doesn't know the proper treatment, or he can't be better than you. Never treat anybody inferior. You can keep on learning. It's just a learning process. You learn from your juniors. We learn from our students also at times. So you should not be ashamed in admitting, yes, oh, sorry, I didn't know this. I can improve upon myself. I can improve the treatment what I'm giving, and I can improve on my diagnosis. So this process of learning continues throughout your life, and whether you are a student, whether you are a specialist, or whether you are a subspecialist. You have to keep on learning throughout your life. Very important.
That's right. That's right. Now, Dr. Som, what was your specialization journey like? We know you're a Manipal boy through and through.
Yes.
Yeah.
Well, I mean,
tell us a bit about the work experience and things like that, because you are also on the National Specialist Registry, and I believe that needed about 6 months of experience in the OT.
Correct, that's right. Because they want a local logbook for that. That means operative cases. So that's why we had to, even though despite having the other cases, logbooks and all, they wanted, when I came and joined here in Malacca, they wanted a specifically 6 months attachment and specifically OT logbook. That means the cases I have operated as a main surgeon or the assistant. They wanted all that kind of log. So for 6 months. And then, of course, the head of department of the GH had to endorse me based on those credentials, like whether I have done a good job or not. So
yeah,
it's definitely, as you can see, that's the journey as far as obs and gynae is concerned. And well, some days are good and some days are great. I'll give you examples with some cases on this. Like when I say some days are good, many times you'll come across, like not you, but many times the obstetrics and gynecologists will come across patients, let's say teenage girls coming with menstrual issues, like she's bleeding a lot, and some neighbor told her, who's not much educated, told her, oh, you're bleeding so much, could be cancer. And I've come across patients who come like just 14, 15, and they come so depressed, and just a little bit of treatment and reassurance can actually make them back into their spirit. So these things are really good, like for you, that it's really gratifying. Some days are great. Well, the best example would be labor room. You go there, a patient in labor is screaming, shouting, and God knows doing what. They really don't know. They go into a trance. And the moment the baby's born, they look at you, they feel shy, they feel guilty, and say, thank you, doctor, sorry for everything. And that's one particular feeling, you will nothing can replace that feeling that a obstetrician go through.
Mm.
So no money can buy that feeling, in other words.
Mhm.
But at the same time, the other aspect would be some days are bad. Some days are bad in the sense, to exemplify this, I would say, let's say a relatively younger lady, like around not very old, but 40s or early 50s, they come with some particular symptom, and then on examination and investigation, you find that she has cancer.
Mm.
So to break that news to her and how to decide on the plan, yeah, that's not like something that you would cherish doing it, but you have to do it. So those days are bad. But I
Mhm.
would say the depressing days are the ones when, despite your best attempt, well, you lose the baby.
Mm.
We cannot win all the battles. You see, sometimes preterm they deliver out, and despite all our best attempt, because we always follow the mother first, baby last policy, the mother has to be okay first. I
Mhm.
mean, not like we don't care for the baby, but at the
Yeah.
same time, the mother is our first priority. So sometimes in that battle, we might lose the baby. So those days are pretty down and
Mhm.
depressing days, I would say. Now, my
Mhm.
focus of after doing my specialization, my focus was on reproductive medicine, which is dealing with subfertility. That means ladies planning to get not able to conceive, but they wish to conceive.
Mhm.
Those also had the times, like we had times when after the pregnancy test comes positive and she's actually conceived. Oh, it's a great feeling. At the
Mhm.
same time, after despite trying a few cycles of various treatments, she's not conceiving. So it's, in true sense, it's a roller coaster ride, this
Mhm.
specialization. So you'll
Mhm.
have your good times, you'll have your not so good times.
Yeah, 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 exactly, exactly. And there, I think it's both these fields is one of the more challenging specializations, where both of you sometimes, like, despite everything that medicine and science and technology can offer, you lose the battle, and you can't help but just cast your eyes towards heaven and go,
True.
why?
Yeah,
Yeah,
absolutely, absolutely.
yeah.
And one
Oh,
more thing I want to add on, it's these both these fields are very important when a country's health services are looked into, because
mm,
they call it MCH service. There are, like, community medicine has particular markers like infant mortality or maternal
mm,
mortality.
that's right.
Like infant mortality, if it's poor, then wow, the country's MCH service is looked down upon.
Yeah.
And maternal mortality, if the something happens to the mother, you're on national TV or newspaper.
Yep, yep, yep. We know of countries. Fortunately, it's not quite rampant in Malaysia, but
Yeah, true.
we've heard of horror cases in countries, even in developed countries. Yeah. So let's go into some of the pros and cons of your area. You've both shed some light that it is extremely satisfying in both your fields. When the child has recovered, when the baby is born, and things like that. But would there be any other pros in your area? For example, Dr. Sunil.
Yeah. I'll say yes, it's a very satisfying profession, no doubt about that. You see, working with kids and seeing them grow normally, it's a very satisfying experience.
Mm,
Then you see the parents, and you keep on following the child from the child. And if you're a good doctor, the parents will stick with you. They won't change their pediatrician. So
mm,
seeing the child grow when the child was born to about 16, 17, 18 years of age, when the child it becomes an adult, it's
mm,
a very nice feeling and a good journey. You see,
mm,
when a baby is born, the baby comes out crying, but the first cry, what the doctor hears, what the gynecologist or the pediatrician hears, is the first cry of the patient is the satisfaction for everybody in the labor room. The child
mm.
is crying.
Yes.
So
Yes.
it's not the child is smiling. We don't want to see a smiling child in the labor room. We want to hear the lusty cry of the child, as we call it. So everybody is happy there.
Actually, Dr. Sunil, if I
Yeah.
can just interrupt you one
Yeah.
minute,
Yeah.
because since you talked about the cry, it's a saying in the OT or the labor room that if the newborn doesn't cry, the obstetrician and the pediatrician cries.
Yeah,
So that's
absolutely.
what.
Absolutely. Then it becomes a challenge for the pediatrician to revive the child and resuscitate the child and see that no damage occurs to the brain. That's
Mm,
important, because if the child is not crying, that means the child is not breathing normally. That means enough oxygen is not going to the brain. and later on it can harm the brain, the child will become abnormal.
That's right.
So that is one thing. It's a very, very challenging part, starting from the birth itself. Then later on, of course, if the child is doing well, you keep on monitoring the child is growing well, taking the height, yes, is gaining proper height and attaining normal weight. Then you do the what you call it immunization and protect the child from various illnesses. So that also gives you a lot of satisfaction. It teaches you a lot of patience, communication skills, and many other qualities, in fact, you know. And one thing I'll say in pediatrics is that it's not that you have to be with the patients to 24/7. You can choose after even becoming a pediatrician. If you do not want to see too many patients, then you can go into research work. You can go to what do you call it genetics, where you don't see many patients and all. Or you can, in fact, there's something known as pediatric journalism also. Then you can go to, there are so many fields open to you after that. So sometimes it happens, you know, some people find it very taxing after practicing for a few years. Say, no, now it's very taxing because day in and day out calls come for me. I have to go to the hospital. Children are sick. Sometimes you can't save a child. So that plays on your mind. So some people say, no, I can't practice anymore. Let me go into something else. So you can always choose that. And secondly, if you want to do a subspecialty, you can always do that also. There are various branches. There's neonatology, there is neurology, there's cardiology, growth and development, genetics. There's so many other branches. After pediatrics, you want to go into subspecialty. But like I said earlier also, a smile on the face of the child is the biggest reward a pediatrician can get. But you see, every day, like Prof. Som has also mentioned, every day is not the same. Sometimes, you know, the day is very good when your patients are doing well. Some days are very bad when you get an emergency and you handle that, you lose a child. So those days are also very, very taxing for you.
Yeah.
But all in all, it's a very, very satisfying profession, I must say. And now, like I have come to Manipal there for the last 5 years, I'm only teaching the students on patients. So I don't have that tension of, oh, my child is not doing well in the ICU, or I have to go and see the OPD. No, I only have to teach the students and concentrate all my abilities, all my time on teaching, basically, so that the students become good doctors and a better doctors.
Yeah. Yeah. And our students are definitely benefiting from your many years of experience and the different scenarios you've seen. Now, Prof. Som, I find it interesting that you've indicated here that obstetrics and gynecology can make a big difference in society via education and awareness.
Yes,
Would you like to elaborate on that?
Yes, actually, I was thinking I'll exemplify with a very simple condition, yet a very common condition called cancer of the cervix. Cancer of the cervix is so common that if I can give you a stats, like every 5 minutes, one lady in this world is dying because of that, every 5 minutes. So that means if this webinar is for 50 minutes, we've lost 10 ladies in that time. But the funniest thing is that this cancer is totally preventable. So that is what I have actually worked on the last 2-3 years. I've been working on that to improve the quality of life as well as prevent CS cervix or cancer cervix by promoting either the vaccination for cancer cervix, vaccination against cancer cervix, and also the various screening techniques which the ladies can actually go for to make sure that they either don't get the cancer, or if they get the pre-cancer state, they're detected earlier and get a 100% treatment. So that is why I said it makes a big difference in the society. And some countries like Hong Kong, Singapore, actually their cancer cervix rate is so less, virtually nil. So that is another thing, like it can definitely improve the societal condition and the quality of life amongst the ladies. And if they can also advise their girls or their like the ladies in their family, it's not like just one. If we can educate one, they can actually spread the education to others as well.
Yeah. And do you work closely with community med, with ComMed, for this education and awareness?
The closest I go is like of course GH, we usually have the referred cases only, but the unreferred or direct cases we can get usually in Jasin Hospital. That's where we see more or less the I would say the cases coming from the Kampong side or the like they may just come walk in also.
Yeah.
From directly from the KK they are referred to Jasin
Yeah.
Hospital. So per se, like community medicine, we do communicate with the community medicine people in case they have something in the Perengate clinic or the other KK. They do talk to us and we discuss. But per se, we don't go out unless there is some camps. If there are camps, yes, we go for those camps.
Okay.
Yeah, I just like to add here, Barbara, about the
Yeah.
community medicine part as far as pediatrics is concerned. Even ONG, I think, because maternal and child health, what Prof. Som pointed out earlier, is one of the biggest things where community medicine is also interested. They want to prevent maternal mortality and they want to prevent infant mortality. So they play a big role as far as prevention of mortality is concerned and prevention of diseases, immunization.
Yeah.
So there's one thing which is common in pediatrician and community medicine is immunization, where we can prevent diseases in children.
Yeah.
Before we go on to the next topic, I'll just add on here
Yes.
as far as the pros you asked about the pediatrics. There was one study carried out in US. First, it was in the general public, so they wanted to know how many Americans are happy.
Yeah.
So they said that 34% of Americans say that they're very happy. 50% pretty happy and 15% not too happy.
Okay.
Then they went to this was done by Medscape. Medscape is a website where all sort of latest of medicine you come to know there. So they are the US physicians, how happy they were with their lives outside of medicine and to rate their level of happiness on a scale of 1 to 5, with one being the least happy and 5 being the happiest. And you'll be surprised to know that average happiness score for all physicians who responded was 3.96, which is on the cheerful side.
Okay.
Pediatricians, however, they beat that score with an average happiness score of 4.00. So more than all the other physicians. Maybe it is because of the joy of being around children, I think.
Yeah, I would think so. I would think so. And to know that what you're doing, it's the start of a person's journey. And if they live to a ripe old age, if the first 18 years are done right, it could extend that significantly in our world today. Okay.
I was wondering if Prof. Sunil can shed light on the scope for gynecologists there.
I don't know. I'll have to go to that study in deeper and see what is
But definitely not that high, I can tell you. But it depends on the level. Like in the beginning part of Obs-Gyn is really demanding and stressful, especially when you're a junior doctor in Obs-Gyn. But as you go up, responsibility increases, but you have a lot of helping hands. So it becomes slightly better with more experience and age, I guess.
Yeah.
Yes, back to you, Barbara.
I'm going to ask you a interesting question. I mean, this is my personal curiosity.
Okay,
What's
sure.
the most number of babies you've delivered in a 24-hour span?
Alone. That means then I have to take you back to my Maldives days where I was the only doctor, because in GH and all we have many people, so we don't really we have shared work. But Maldives, when I was alone, it was one day was 12.
12 babies.
Yeah, one day, and that's a small hospital, mind you. That's a very small hospital.
And your role is not that you just come in and catch the baby, isn't it? You
No,
got to kind of
I'm like
starts.
that includes the cesareans as well. It's not just the normal deliveries.
Wow.
And it includes the OPDs as well and the rounds as well. So
Wow.
it's that day was a horrifying day, and I came to work at 7. I went back at 2 o'clock. 2 o'clock in the night, that is.
But to welcome 12 new lives in a span
Yeah,
of
I know. But of course, one was a bit critical because the lady came with 3 days of leaking, and she did not come earlier, thinking that she can deliver in her place. And that was, I think, that particular case was the one which we had to hold on, and the pediatrician had to really work hard on that. Other 11 were great.
Excellent, excellent. Now, Dr. Sunil, you've indicated there that pediatrics, emergencies, night calls, and stuff like that. Is it just that? I mean, I think every area of specialization, emergencies and night calls, would be a feature if it's, I mean, if you choose to do an MBBS, but is it more so for pediatrics?
Yeah, ONG and pediatrics are the maximum, I think. Of course, adult medicine also there. But you see, when a child falls ill, the parents don't wait. They always want to visit a doctor, especially a pediatrician, and show the child. If an adult is sick, if I'm supposing I'm having fever today, I can take a pop in a paracetamol, pop in a pill, and wait. Oh, I can go to the doctor tomorrow. But if a child falls sick, the parents always want to go and visit the uh, doctor, especially a pediatrician, immediately. So that adds on to the calls. So sometimes there's a lot of heartbreaks also there when we are practicing pediatrics, because I remember very vividly one case which can never forget throughout my life. I was on call there's a city called Jalandhar in India, a very very busy hospital there. So I got a call from the doctor in the hospital that this child has come with snake bite.
Oh.
Yeah. So went to the hospital there. The child was in the ICU, and you see the irony of the things. The child was the son of a nurse, and this nurse was on duty in the ICU.
Oh my.
Yeah, and this child was being looked after by another nurse at home. And somehow she saw this. Suddenly, the child got up in the middle of the night and started screaming. And then she saw one snake wriggling out and going out of the one of the passages somewhere, went outside the room. So she immediately brought the child to the hospital. But the snake bite was so severe
Yeah.
that when I reached there, we started the treatment, but unfortunately, we lost the child.
Oh my.
And there the mother was watching the child being treated. I mean, I couldn't have had a worse time ever in my life. That one thing I can never forget.
Yeah.
So those are some heartbreaks which you have to go through. I mean, I couldn't sleep for many days after that.
But at the same time, you indicated there reading and studying throughout life. I would think both of you, with your many years of experience, you will always have this one patient that will stay with you for the rest of your lives.
Yes.
But it is also the reason why it spurs you to go on to do
Yes.
subspecializations, research,
Absolutely.
and things like that, isn't it?
Absolutely. We have to study. We have to keep on reading because the medical science is advancing so fast. I mean, very difficult to at times keep up with all the fields in medicine. But at least in your field, you have to keep update in the specialty. Whether
Yeah.
you're treating a patient or whether you're teaching students, whether you're teaching undergraduates or postgraduates, you have to read. There's no two ways about it. There's no shortcut to studying, whether you're an MBBS student or you're a postgraduate student or you're a doctor or you've got 45 years experience, doesn't matter. You have to keep on reading. You have to attend conferences, learn more and more, learn what is new in your field. So that never goes up. You have to.
Yeah, excellent, excellent. So we know that there are many similarities. I mean, there's one distinct difference in both your fields. The work of one basically starts after the other.
Yeah.
And it can't be turned the other way. But would there be any others that you would like to point out?
Well, I like to say that an obstetrician and pediatrician, they have to work hand in glove. We have to have trust among each other. The obstetrician has to have the trust on the pediatrician. The pediatrician has to believe that whatever the obstetrician is doing best for the mother and the child. You see the baby inside. You see the obstetrician got more responsibility. He's dealing with two lives: life of the mother, life of the baby, which has to be delivered. And if anything goes wrong there during delivery or even prior to delivery, I mean, doctors, we find that we can't excuse ourselves. We of course, we try our best. We try our best to save the life, but sometimes things do go wrong, even with the best of efforts.
Yeah.
So that is one area where you have to have teamwork. You have to have trust. More than teamwork, I should have trust in each other. That's more important.
Okay. All right. What about you, Prof. Som?
Yeah, I just put it as love and hate relationship, the peds and the obs, because I mean they will work hand in hand, and or hand in gloves, as Prof. Sunil mentioned. They will go out for coffee together, but sometimes they might have bitter arguments also. But all this is done for the well-being of the baby and things like that. Ultimately, they are a team. And I just wanted to give you an example. Like I was telling that story about one lady who came with leaking for 3 days, and she did not inform. And so basically she had a major infection. In medical terms, we call it chorioamnionitis. So that means the amniotic cavity and the liquor and all has got infected, and the fetal heart rate was shooting up to 200. So we decided to do the Caesar for that patient. And my pediatrician that time was, he was 10 years older than me, but we were in a first name basis kind of thing. And we used to go out, hang out, have dinner and things like that. And every time the baby cries, I look at him and I give a wink, especially in the OT, and he'll give me a wink back, kind of thing, that kind of understanding. So, but this time I told him, like, this baby comes out, baby makes the first cry, it's your baby, jokingly. But somehow this time he was not in a mood of joke, and he did not reciprocate my love, and he actually gave me stares. So I would say, but ultimately, of course, this was a happy story because we managed to salvage both the mother and baby. But the thing is, it's the stress that we go through at times. So it's just the roller coaster I showed. It's a teamwork between both, and as Prof. Sunil said, yes, you have to trust, and it's a blessing for an obstetrician to have a very good pediatrician by the side, and also for the pediatrician to have a good obstetrician, so that he or she doesn't give the pediatrician always bad or flat babies and things like that. So ultimately, both, whatever said and done, love or hate, their role is to give a healthy mother and a healthy baby. That's what they work towards in this specialty. So they have to forget their own emotional differences or something. But the problem is the medical legal thing is also very high. So I think that also brings in a bit of stress amongst both. So sometimes there might be finger pointing. So those things are also there when you actually see when things go wrong, that is. Otherwise, they're like best of buddies.
Otherwise, I would think so. Yeah. Okay. Now, you both given us plenty to think about, and our future doctors tuning in. Would you have any words of wisdom for them? Let's start with Dr. Sunil.
Yeah, definitely. I mean, for future doctors, I'll just say one thing, that it's a very fascinating journey. As students now at present who are wanting to become doctors, like, the human body is so complex. Sometimes you wonder what's going inside the body. And if you want to learn that, you must become a doctor. You're right from, pumping of the heart. The heart keeps on pumping. You don't even know. You're moving a finger. You don't know what's moving your finger. How is it moving? How the fingers are more sensitive than your toes. How you can pick up a pellet with a finger, but a finger and a thumb, you can't do it with the toes. So all this is very fascinating. But this you can learn when you do medicine. Then you have machines which can allow you to see inside the person. And I think modern medicine is one of the most fascinating subjects. But yes, you have to have trust in other people. Also, you gain trust of other people when you become a doctor. You'll find that it's a very respectable profession. Doctor being a very respectable profession. I mean, if you're supposing you're going to the market also, you want to purchase something and you tell them you're a doctor, you can see the respect in their eyes, the people who are there. That definitely your respect goes a notch higher. Again, when you become a doctor, you always have very exciting moments. There's never a dull day, either being inside the hospital or being outside the hospitals. Then you do develop critical thinking, and you can solve the problems better because you're always thinking for the better of your patients. Then you always build meaningful relationship, whether it's with your parents, with your colleagues, or with your patients, for everybody. And of course, the job stability is there. You never lose a job. Even whether there's corona or no corona or whatever may be the thing, you never lose a job.
Yeah, and I mean the jury is still out whether young children are conduits of the virus or not.
No.
We've lived with coronavirus for coming to 8 months now, and they still can't decide are young children vulnerable or they're not.
Yes.
So there you go.
And as far as the money is concerned, there's adequate monetary compensation. You can earn a decent living, though it may not be the most paying. Maybe in the corporate world, people are get paid much better. As a doctor, you may not be paid that much. But let me tell you, it's a more satisfying as far as your profession is concerned, because it's not just a profession; it's a service. Medicine is a service, and you have to always put others first. You have to put your other needs first. others' needs first than your own personal needs.
Yeah. Your
So
patient's needs
there's
before
an
your
yeah,
own. Yeah.
yes, and
Yeah.
there's an element of sacrifice which comes in there. So
Mm-hmm,
that's
mm-hmm.
all. I mean, if you want to become a doctor, you must have these. But of course, you have to take your own call. If you
Yeah.
want to become a doctor, then a self motivation is required.
Yeah.
You should have an unshakable reason that you want to pursue a career in medicine. You have
Mm-hmm,
to work very hard, be diligent, sincere, have compassion, empathy.
mm-hmm.
So all these factors are required. And I'm telling you, if you have all these factors, not a good doctor, you'll become a good human being also.
Thank you so much for that. Thank you so much for that inspiration. And Prof. Som?
Yeah, I actually summarized the words of wisdom that I would want to give in these four phrases. One is passion for your work that you do. Now, as doctors, yes, whether it's private or government, you will earn money, but you may not become millionaire just by being a doctor. So ultimately, it boils down to the passion of doing the service or being a doctor. Because without passion, after some time, you might end up frustrated. Because sometimes you have to do things which are unconditional. You cannot always convert everything in terms of money or return of investment.
Yeah.
Second one would be communication skills. Sometimes, probably you've heard that when a patient talks to a doctor and say, after talking to you, doctor, 50% of my problems are gone.
Mm.
So it's very important how a person talks to the patient, not only patient, interpersonal communication as well. Because there's a saying that all gold medalists need not be the best doctors. So it
Mm.
also depends on how you talk to your patient or peers or patient party. Empathy for the patient, I think Prof. Sunil also touched upon this as well. Empathy for the patient, when I teach my students, I tell them, like, just imagine this patient is maybe a relative of yours. How would you look at that? Now, you don't have to, like, just look like, okay, this is a person with a disease and I'm going to treat the disease. No, that's not how you look at the thing. You have to, like, understand what is the person going through,
Yeah.
and also have some, I'm not saying you have to get emotionally attached, but you must feel like, if I were in this person's shoes, how
Mm.
would I have reacted to it?
Mm.
Finally, perseverance. As I told you, medicine is a tough field. You cannot be a softie, you need to be a tough cookie, because there will be tough times, not just the work wise, there would be pressure, there would be seniors scolding you for, sometimes you've done the thing right, but they are stressed, they just scold you to get rid of their stress, they went out. So there are many times when you just get scolded unnecessarily also for doing the job
Yeah.
properly as well. So this, you cannot take all those things into your heart, you just have to take them in your stride and move on. So perseverance to ensure that you survive throughout. You cannot
For
be
your
a
own
softie.
sanity.
Sorry.
For your own sanity.
Yes, I mean, you got to be, like, tough. You got to be tough. Like, this is a field, like, now so many doctors are going fighting with the patients, like, for corona. I'll give you an example. Like, there will be disappointments as well. Like,
Mm.
yesterday, I was supposed to meet up quite a few students from Sebrangja Hospital.
Mm.
And evening, I was supposed to meet them up at 6 o'clock. 5 o'clock, they call me and say, Prof. Som, three of us got exposed to a patient.
Mm.
Actually, it's a doctor who was
Yeah,
transferring a patient to Sebrangja,
that's
and
right.
she turned out to be positive. And so they're
Uh,
saying, no, I don't think it's a good idea to meet you because you've just come from Malacca to here. So the meeting got cancelled. Now, you have to also be ready for disappointments
mm.
when you make plans and things like that. You cannot
Yeah,
be very, very emotional person at the same time. That's all
right.
from my side.
Thank you so much. Now, thank you both. If you've been tuning into the Malacca Manipal Doctor's Road to Specialization, where we've been joined by Professor Dr. Sunil from our Pediatrics Department and Professor Dr. Somsubhra from our Obstetrics and Gynecology Department. They are both senior faculty members in our MBBS program, where we have 2 intakes a year and where you do the 10 semesters starting this October in Malaysia, and you have your first 4 semesters of preclinical theory, which includes cadaver dissection in Malacca, and subsequent your clinical exposures from semester 5 to 10 in various hospitals in the states of Malacca and Johor. One of the key points of our MBBS program is that in semester 10, you undergo what we call shadow housemanship, which readies you for the real world. We are one of 2 medical schools in Malaysia which is structured this way. So if you're still shopping around, do feel free to get in touch with us. We'll tell you how at the end of the session, and we hope that you would consider joining us. Now we have 2 questions that have come up, and this is for both Prof. Sunil and Prof. Som. Both of you shared your specialization pathway after your MBBS in India, where it involves a exam and things like that. What about in Malaysia? Now, after one completes their MBBS in Malaysia, they have to serve, become a houseman for 2 years. How do they progress into pediatrics or obstetrics and gynecology after they complete their housemanship? Maybe we could start with Prof. Som. How do they do that for obstetrics and gynecology?
Okay, fine. So the 2 years of housemanship is compulsory. After that, another 2 years of medical officership has to be done. Now this one, usually it could be either contract or permanent. So it depends like how they get in. And before getting their MO-ship, they have a period of time, they call it floating MOs. Floating MOs means the KKM decides on, the health ministry basically decides where they want to put this not students, these doctors after housemanship.
Okay. And
Float
and
in
then,
their own hospital.
Right.
Sorry?
Yeah. Sorry, continue.
After that, they have to they will be openings depending on the years of experience. This is in my previous slide. I mentioned about MOH pathway.
That's right.
So they will have a selection of depending on the amount of years you have spent. It could be 3 years, it could be 4 years as MO, and they would open up interview segment or sometimes a written exam to get a master's program of 4 years in the MOH system.
Right.
But now there is something called the alternative pathway. That means this is a membership exam from the Royal College of Obstetrics and Gynecology, RCOG. It's called MRCOG. The part 1, they can write the moment they finish their MBBS. That means they're registered. Right. They're registered with KKM or MMC. They can actually write the part 1. There is a part 2 and part 3, which is actually advised that once you finish a certain amount of OBG posting, you should write, because these are very clinical orientated and critical thinking exams. So you need to know a little bit about the subject. You just can't write with the MBBS knowledge. You need to have worked for a while.
That's right.
And once they finish the part 2, which is a theory exam once again, and all these exams are either single best answer question or extended matching question. And part 1 you can write, part 1 and part 2 you can write in Malaysia, in KL and in Singapore. They're usually held in March and September, whereas part 3, Singapore has a center, but we usually advise our students to go to UK and write the exam. That is OSCE based. So once they complete the 3 segment, part 1, part 2, part 3, following that, they have to do a 6 months gazettement period in the with the government hospital in Malaysia. And after that, they're deemed specialist. They can actually leave the government and join a private, because by that time, they would also be applying for their NSR. NSR is required for private practice as well. So this is the alternate pathway. And the other pathway, as I mentioned, was 4 years of local masters, followed by which the 6 months gazettement period, following which they're deemed specialist, and they can either continue their life in government side, or if they so wish, they can leave the government side and join the private side as well.
Okay. And Prof. Sunil, the pathway for a pediatrician, I believe, is quite similar, except...
Yeah, it's quite similar, only, same MED, what we call it, the MED or MRCPCH. It's not MRCOG in gynecology and MRCPCH in pediatrics. Again, MRC, CPCH is also same. Three theory exams and one clinical exam after the end of theory. So the similar thing that depending on which specialty you want to choose. And then of course you have classes also for that. Coaching classes are held in MMC also, and Professor Som is in charge of that. So they do have MRCOG classes here in MMC also.
Yeah. Okay. And
I want to add one thing actually. I think we missed that out. In case of if they're planning on the alternate pathway for MRCPCH, that is pediatrics, they need a minimum training period of 2 years. Whereas if they wish to do for MRCOG, then they need a minimum training period of 4 years. But the good thing is the gazettement for obs and gynae is 6 months, whereas pediatrics is a bit long. I think it's around 18 months. Because it's more medical oriented. Even for MRCP, that is the internal medicine also is 18 months. So the medical fields, they keep 18 months of gazettement, whereas the surgical field, it's only 6 months.
Okay. All right. Am I correct, Prof. Sunil, to say that if one is thinking of becoming a pediatrician, they have to know all aspects of internal medicine, but tailored to a smaller being?
No, I'll beg to differ on that. It's not the same thing. Child is not an adult, or adult is not a small child. So it's totally different, because the diseases what we see in children are different from diseases what you see in adults. Yeah, some of them, maybe similar, but like for example, I'll give you neonatology. That is when the child is born, newborn baby. Newborn baby, the illnesses you see in newborn baby are not seen in older children or adults. Some children, some congenital anomaly, that is when the baby has some defect in the body by birth. That is, it may carry on till adulthood, but normally you see that in children, hardly see in adults. So there are so many, some similarities are there, definitely. As far as the examination of a patient is concerned, the basics may be the same, but art of examination of a child is different, and art of examination of an adult is totally different. Because you see, when you examine a child would be crying, small child. So firstly, you have to first control the child. Otherwise, if the child keeps on crying, you can never examine. So it's quite different. It's quite different. I won't say the same, actually. It's quite different from it. Otherwise, there won't be a separate specialty for pediatrics.
That's right. That's right. Thank you. That was a cheeky question on my side. Okay. So thank you both very much. We've got no other questions, and we thank our viewers for tuning in today and joining us. We are from Malacca, Manipal, based in Malacca, 90 minutes from the capital city of Kuala Lumpur, one of Malaysia's oldest and most established private medical and dental colleges. We've got over 1,000, my apologies for that typo, we've got over 1,000 patient beds available, which means that if you are a student doing your MBBS with us, your exposure in all the major areas, which includes pediatrics and obstetrics and gynecology, would be quite vast, and 90 minutes from KL. So we are near enough for you to have some excitement, but far enough for you to not be distracted on a daily basis. And with globally experienced faculty like Prof. Som and Prof. Sunil, who will be ever ready to assist you in preparing for your specialization and destination of choice post-graduation. Thank you very much once again, everybody, for tuning in. In the words of Carl Jung, medicine cures diseases, but only doctors cure patients. We wish you well in your weekend and in your journey ahead. Do follow us on Facebook, which is Triple MC Malaysia. I repeat, Triple MC Malaysia, if you haven't already, so that you could stay tuned for more events like this in time to come. In the meantime, stay safe, take care, and we will see you again soon. Have a great weekend, everyone.
Thank you.
Thank you, and bye-bye, Barbara.
Thank you.
Bye.
Bye. Bye-bye.